Now, breast is the most potent weapon of Jean-Luc Godard, a French film director. And this is the breast or mammary gland. This is a picture of a woman with multiple breasts. That means it represents some mammals. You think of dog. Okay. Now, everything which I am trying to present to you, there is some thought behind it, idea behind it, that relates to your subject. If you feel it, it's a bakwas, it's a bakwas. But if you go into the depth, I'll just narrate this picture. I have many interests. I frequently visit Subarna Rekha, a well-known bookstore at Santiniketan and also in Kolkata, who sells old books, old magazines. And Santiniketan bookstore, one day I came across an art magazine, this picture. I asked Indroda, we should call him. He died. His son is there, looks after the store over here. And Kolkata, anyway, that now, at the first glance, I picked up the magazine. Then I told Indra, Dada, eta koto hobe? What is the price? Oh, tumi 100 taka debe. The thick magazine like this. I saw this picture, it really gave me a thought. And someday, wherever I talk on breast, I will put this picture. It is a fiberglass sculpture made by an artist. I don't remember the artist's name. And this is the breast is the most potent weapon of a woman. Jean-Luc Godard is a great film director, French film director. Now, why I am putting these two things? You please think. Even also you think. Now, this is the adult female breast on the right side of the mammary bed. See, this is the pectoralis major, and this is the areola, this is the nipple, this is the mammary gland, this is the foramen of Langer, and digitation of the serratus anterior, and external oblique over here and over the rectus sheath. This is the presentation. Now, you have to know the anatomy. I have done numerous operations on breast, and if I thought there was no FNAC, no ultrasound, that remove the whole breast according to the clinical presentation. I removed it up to the pectoralis muscle under local anesthesia. I usually, by personal this thing, I don't like to take out the axillary lymph nodes and all this, because we exactly cannot mark where the metastasis is gone to. But nowadays you can do a PET scan and all this, you do ultrasound, you see the localized mass and this thing. Now, this is a non-pregnant inactive duct. And during pregnancy, alveoli proliferate at the ends of the ducts. These are the alveoli. And lactating milk secretion and accumulation in alveolar lumen. Now, many ladies, they are not pregnant. Many girls, they are not pregnant. But there is some hormonal imbalance, or you see that there is lactation or white fluid coming out. So whenever you examine a girl or a lady, you question, you ask in the history taking that are you some lactating? তোমার এখান থেকে কোনো দুধ বেরোয়? So you have to know the cause behind it. Now you see the superior thoracic artery and lateral thoracic artery. This is internal thoracic artery. These are the key arteries supply of the breast. So you ligate these two branches and you can operate it with minimum bleeding. Now see, this is the venous drainage of the mammary gland. This is the azygos vein, the posterior intercostal vein. This is the internal vertebral venous plexus and internal thoracic vein and axillary vein, circular venous, in the areola. Now, see, a woman comes and tells you, and she walks with a pain over here, she has a fracture. So your first thought will be that it is a metastatic tumor of the breast. Okay. Now, now this is very important. All this can come as a small question. Chart number. Okay. See, this is the breast and you can see the lymphatic. Now this is the anterior group, this is the axillary nodes drain 75% of the breast axillary lymph nodes, parasternal group 20% and 5% intercostal nodes. Now you can see the apical, this is the anterior group, this is the intercostal nerves 5%, intercostal space, these are the parasternal 20%, axillary nodes 75%. Lymphatic from the parenchyma of the breast. Okay. Now you see lymphatic from the overlying skin of the mammary gland. The overlying skin of the mammary gland. And see infraclavicular nodes, the supraclavicular nodes and parasternal nodes, axillary nodes, this is the hepatic nodes, this is the supraperitoneal lymph plexus, supraperitoneal lymph plexus, and this is the ovary. Now, whenever a patient comes with the breast, problem with the breast, not think of always malignancy and this, don't bring that into your head. First, you take a small step and look for routine X-ray chest, routine USG of the sol. Sol means the space occupying lesion. Space occupying lesion. Okay. Now, plus FNAC, fine needle aspiration cytology. Fine needle aspiration cytology. You take that, put that smear in the slide, on the slide, and then send it for your histopathology. Not histopathology, fine needle under some stains, you will see that it is the abundance of nuclear stain in a routine H&E stain. Okay. Now, and see, you do an ultrasound of the abdomen because metastasis goes into the liver and also the ovaries. That is a severe case, very severe case. But 1, 2, 3, 4, 5 X-ray chest, USG, then your USG whole abdomen, FNAC. This is sufficient. It gives you this data to come to a conclusion that you have this thing. This is a part of the diagnostic tools you are using. But your feel. You ask the patient with an attendant, female attendant. Most of these polyclinic in the roadside shop, they have female attendants. So call the mother or any woman who's she's come alone or with a child. Then you ask the child to sit down. He might bother you, so you take a chocolate or something, bring a chocolate and give it to him. And the mobile phone. This is the food early in the morning. All the children are taking in, seeing reels. So for 5 minutes, you can take that child outside and bring in any lady to stand. Okay. Because you don't go to do a vaginal examination or gynecological examination or breast without an attendant. Now, this is the mammary ridge, mammary streak, accessory gland and nipple, mammary gland and nipple, mammary ridge, mammary streak. This is the embryological part. Now you can see the milk line here or the mammary streak. So there can be in this region, now all these small breasts are there. But all this did get degenerated and vanish. Sometimes you have two breasts, a small breast here, or a breast in the axilla. When this axillary breast, there's some tissue is there, it might lactate, is when she becomes pregnant, then it swells up. So she might come with a presentation like this. Also, there is some axillary fat, sometimes unequal distribution of the fat. Right side might have a big swelling, left side there's no swelling or minimum swelling. So you have to ask her if she's married and ask her during pregnancy, did this swell up? Did you have any pain? Or it can be your abscess. Okay. Now, can you correlate that first slide of that woman with the hair on both sides and the breasts, multiple breasts? Can you correlate? Okay. Now, this is triple assessment of breast symptoms. Triple assessment, see, clinical, imaging, pathology. Now, clinical age, examination, and confident diagnosis in 99% of cases using imaging, USS, ultrasonography, mammography, even CT mammography is now. To become more exact, have a more confirmed diagnosis, mammography, FNAC, and your cord cut biopsy. Final aspiration cytology might not give you exactly some tissue. It can be a small thing with scattered cells and all. But the smear can be a small needle is there. You take it out. And it might not target the area where exactly the small nodule is there. So you do a true cut biopsy. Now, you see 99% of the cases. Now, triple assessment of breast. Now you see, examples of accessory breast tissue. Okay, mediolateral oblique mammographic views of breast demonstrate asymmetric tissue in the right axilla. See, this is right axilla, asymmetric, this is big. See if this is normal. See, this is big. Now, overlying the pectoralis major, this is the pectoralis major. Now, and in the right axilla, arrow overlying the pectoralis major B, corresponding targeted ultrasound of the right axilla shows benign tissue consistency with the accessory breast tissue polymatia. Embryologically, this is a result of incomplete regression on the right mammary ridge at this location. The pectoralis major muscle and deep fascia, this is the pectoralis major deep fascia, pectoralis lamella, anterior lamella, this is the anterior lamella, posterior lamella, superficial layer of the superficial fascia, the deep layer of superficial fascia, subglandular space, corpus mammae, epidermis, dermis and subcutaneous fat, this portion. Now superficial fascia, campus fascia, and this is carpus fascia. Okay, now you see these tissue planes, the fascia, this thing. You just don't go, no. You cut, you can remove it. This is, you have to know the anatomy to doing very good surgery. So, now, two facial layers are present, superficial and deep layers of the superficial fascia, which surround the breast parenchyma. The fascia forms septa called Cooper's ligament. These fascia, they put in Cooper's ligament. These are all the tissue, the breast, these ligaments, Cooper's ligaments, which attach the breast to the skin anteriorly and to the fascia of pectoralis deep fascia posteriorly. They also run through the breast, providing a supportive framework between the two facial layers. If there is a malignant tumor which causes infiltration and shortening of the Cooper's ligament, there will be dimpling of the skin. And on physical examination, mediolateral oblique, okay, And mammographic view shows Cooper's ligament yellow. This is the Cooper's ligament. This. Now you see ligaments yellow arrow, which attach the superficial layer of the superficial fascia to the skin. Also shown is the retromammary subglandular bursa or space white arrow. This is the retromammary. Now which contains loose connective tissue and additional Cooper's ligament that attach the breast to the chest wall. Now, see, nowadays, women are, even the village women I'm saying, they are conscious about their breast. They have any problem or she feels some pain or any complaint, you see that lady, do the investigation and also advise her to wear a bra from morning to afternoon, then afternoon to your 4 p.m. Then 4 p.m. she wears the bra up to 10 p.m. That gives her support. Okay, because it often nowadays the common dresses are there, a salwar kameez and your maxi or your nightgown throughout, from elite to the village folk. So when I ask, hey, bra porish na keno? Why don't you wear a bra? Oshubide. But when she comes as a patient, you try to educate. Je tor eta labh. Now, now you see, this is a malignant growth. The invasive ductal carcinoma in a 45 years old woman with a lump in the left breast for 6 months. A digit clearly shows an oval shape, relatively well circumcised, and circumcised primary mass. The breast tomosynthesis image provides better depiction of the microlobulated spiculated border of the mass, a finding suggestive of malignancy. These are just. Now, there was a time that you see without it, you would just remove the whole mass. But now, local lumpectomy. That's why they are using endoscopes. And they are taking out the tumor mass. Then the tissue biopsy comes carcinoma, then go for chemotherapy, then followed by radiotherapy. Okay? Now you see, the accessory breast. This is the true breast, this is the accessory breast. Now you see, recent nipple retraction, site like retraction of the duct ectasia with mammary duct fistula, this, and circumferential retraction underlying carcinoma. Circumferential, the nipple and the areola is only pulled in. And now, see, bilateral accessory breasts. Dr. S.S. Rawat, Saudi Arabia. She is an Indian. See, this is the presentation of accessory breasts, which comes into activity during pregnancy. Now, see, congenital absence of the right breast. the congenital abscess. This is the papilloma of the nipple. This is our Indian surgeon, Deshmukh from Nagpur. See, this is the papilloma. So when you see this type, it's very small size of a pea. It can be big. So you just excise that. Of course, you take the investigation, that is, then you excise it and send it to histopathology. Now, this is the inflammatory carcinoma of the breast. This is inflammatory carcinoma of the breast. Okay. Now, see, this is the inflammatory carcinoma of the breast. This is a breast abscess, inflammatory breast abscess. See this change. You see this. Now, extensive intramammary abscess. This is the extensive intramammary abscess. Now, this is very common. A woman comes with a few glands over here and there's some discharge and this is tuberculosis. There's secondary suppurating lymphatic nodes. This is the secondary suppurating lymph nodes. Even you have tuberculosis of the neck and the secondary suppuration is there. So you test for routine for the examination which I told you earlier, plus you have an X-ray chest, you take this smear. Of course, now there are some histochemistry study you can do, you will get confirmed that tuberculosis. But your clinical knowledge will tell you also this thing. So you can go for antitubercular drugs and of course local dressing. Local dressing, it can be any ointment or just to give her comfort that something is being done, one thing. Suppurating, discharge is there. Naturally, you have to be, let's see, you have a big fungating carcinoma. হাত তুলে দিল না এটা হবে না এখান থেকে যান ওখান থেকে যান এখান থেকে যান টাটা যান এই করতে করতে দেখা গেল see the big fungating carcinoma it is a sight of horror একটা ভয় যে আমার কি হয়ে গেল at least bring her in a comfort zone this is my opinion. This is my personal experience and opinion. But we might differ with other people, or I might differ with other people. So I will just narrate a story. Actually, one of my in-laws, she had a carcinoma of the breast. Suddenly it got fungating and then profusely bleeding. They put a bandage. From Shingur, they traveled to Santiniketan. I immediately requisitioned 1 unit blood and immediately under local anesthesia, I removed it. Now there's two aspects of this. One mental, psychological, and one is saving the patient. I'm not doing any harm. From Shingur to Santiniketan. After that, after the reports and everything has come, one of our professors, very old professor, he was in Bardwan. I sent this patient to one of our senior Dada of Bardwan Medical College, Dr. Santiniketan Banerjee. He was, I think he's in the oncology over here in professor, I don't know if he's retired. I told him, that day he was not on duty. Then the letter I gave to Santiniketan Banerjee, I'm not naming the professor. I had done a lumpectomy. He commented that, hey, so যেখানে যেখানে সেখানে অপারেশন করে দিচ্ছে লোকজনকে. Then the patient was under Santiniketan Banerjee. I told him, the professor, how many follow-up cases he's done, he's seen. A patient party of a family, if the patient dies in my hand, that family will return to me for any small advice or big advice. That much confidence I have. But later on, this lumpectomy is the talk of the day. বোঝাতে পারলাম? আমি বোঝাচ্ছি কোন জায়গাটা যে রিলিফ দাও. Hahnemann, Lord Hahnemann, he's a homeopath doctor. He was an allopath, then he became a homeopath, the father of homeopathy. He says, treat the patient, not the disease. I have no this thing of homeopathy, allopathy, all this. I don't. Patient should be in the comfort zone, should be treated from any pathy, even jadoo, maduli, mala, anything. Okay? Now, this is a tuberculosis patient. Now, see subareolar abscess in duct ectasia, this, and mammillary fistula, here mammillary fistula, this, originating in a chronic subareolar abscess. This is the bilateral duct ectasia with fistula, bilateral. Now you see galactocele. It's a galactocele, means encapsulated mass with milk. So don't put an incision the very first week you see and make an incision. Wait, if she is lactating or not. If the child is 6 months or 2 months or 3 months or 4 months old, at least one breast or both the breasts, she can breastfeed. The child, then you defer and then you give some drugs to stop the lactation and then you take out the galactocele. See, a galactocele, a 27 years old multipara with progressive breast enlargement following confinement, is from Nigeria. This is a patient from Nigeria. Now you can see phylloids tumor, phylloids tumor. It's actually non-malignant. Most of the cases are non-malignant. Phylloids tumor of the breast is weighed 4.9 kgs. Note the ulceration due to pressure. This is the ulceration. Tumor not a carcinoma of the breast. This is Dr. Karmakar from Bombay. Now these are chart, it's old statistics, chances of developing breast cancer related to age. 87 to 1988 to study okay, in the USA. Now see, enormous fungating carcinoma of the breast with enlarged axillary lymph nodes. See the axillary lymph nodes here, can be like this. Even in inguinal lymph nodes, see, it becomes like this. I have a photograph taken by me in my collection. But this is the breast, and you see the beautiful tattoo. This is a lady from Patna, and Professor Thakur has reported this. Now you see lymphangiosarcoma developed 3 years after radical mastectomy. Patient well many years after full quarter amputation. Now there was a metastatic carcinoma being reported, and then again they did a amputation of the arm. Now you can see these are the operations. This is the cramp flap. These are the prosthetics, breast prosthesis. Of different sizes, like equal size, you order for it, comes, it's available in India. But again, it has some disadvantages. Anyway, lady who can spend, you can offer her that, would you like to have a prosthetic breast? Okay, then you order for the size approximately. You just measure the circumference and the depth, this thing, and the cup size, and then accordingly, one size less, then you take a flap and put it in. This is one thing. Now you see carcinoma of the male breast. This is a common male breast. It is not uncommon. It can be this thing, like inguinal hernias. Inguinal hernias are common in females also. But not, it does not exist, you don't say. Similarly, advanced carcinoma of the breast, carcinoma of the male breast, yeah. This is London Hospital, England. This is Bhamnagar, India. Now, Chief Chengo Wei from photograph of, he is the African chief. This is a picture taken from Bailey and Love. Love and Bailey, or Bailey and Love, okay. So I clamped and then cutting it off. Even if I have a diathermy or anything, I still clamp or ligate and then cut. So there is minimum blood in the field, operative field. And anyone sees blood, panic is there. Even I panic sometimes. Okay, now that's removed. Dressing. Now see, only Dr. Ghosh is assisting me. Dr. Ghosh is a homeopath doctor. Actually, I definitely use needle holders, and but big needles I used to this thing suture without any needle holder with my hands. See, this is the drain. That whatever post-operatively the collection is there, any minor vessels and all, but that collects, it will again swell up. There can be an abscess and all. So that thing is drained, and after 3 days, 72 hours, we see there is no soakage and all, then we remove the drain. See, this is being dressed with honey. Honey. Postoperative dressing with no powder, no lotions, anything. We are dressing with the honey. This is Dr. Mohadev Ghosh. Actually, he died at just 7 years back. A wonderful assistant, and also his dressing. I taught him, but he didn't like any rotten case. He used to dress. Now, with this, I'm at least see. One told you that a good MBBS is a good PG. You have your own practice. You did not get PG, but you become a very good assistant. You can earn at least 1 lakh. It can be a laparoscopic surgeon's assistant. It is the skill you have to develop and also become knowledgeable in your anatomy. That's a gateway to medicine. Even if you practice medicine, you practice anything. And wishing next Thursday, I have taken a leave of my function. A family function means Kali Visarjan. We have a goddess Kali, 150 years old. So I won't be there. If there is any person who will be appointed to take my class, I don't know. That will be put up in the board or your WhatsApp group. Anyway, those a few are coming to me for osteology. Please come.